Hello, and welcome to the June episode of Discussing axSpA, our spondyloarthritis podcast series, in which we will bring you up to date with the latest research and publications in the field of axSpA. My name is Sofia Ramiro. I'm a consultant rheumatologist and senior researcher from Leiden University Medical Center and Zuiderland Medical Center in the Netherlands. And today I'm joined by Xenofon Baraliakos, Professor of Internal Medicine and Rheumatology at the Ruhr University in Bochum. If you would like more information on the papers we discussed today, please head over to the Immune-Mediated Inflammatory Disease Forum website at www.imidforum.com, where you can view full slide summaries of these publications. Today's discussion will focus on two papers. The first, looking at treatment outcomes in European real-world patients with axial SPA and PSA treated with Secukinumab, and the second, reviewing the effects of Secukinumab on skeletal, microarchitecture, and vertebral fractures in patients with axial SPA. So, Xenofon, I hand it over to you to start with the first paper, please.
All right, thank you so much again. And indeed, I'm happy to discuss these papers. So our first paper is a recent publication from Pons et al. And it has to do with the 4 years, or it's entitled 4-year Secukinumab treatment outcomes in European real-world patients with axial spondyloarthritis and psoriatic arthritis. Regarding the study background, it has to do with Secukinumab, which is a fully human IgG1 monoclonal antibody targeting IL-17A, and it represents another approach in the treatment of spondyloarthritis as compared to TNF blockers, as most of us would know. Secukinumab has demonstrated sustained improvements in signs and symptoms of both axial spondyloarthritis and psoriatic arthritis in RCTs, and in 12-month observational studies as a follow-up information. There is currently no real-world evidence on long-term observational follow-up of patients treated with Secukinumab and on the impact of the number of previous biologic or targeted synthetic DMARDs on Secukinumab effectiveness in spondyloarthritis patients. So Pons and colleagues assessed the retention rates and proportions of patients achieving remission and low disease activity according to disease activity measures in patient-reported outcomes at 24 and 48 months in both axial spondyloarthritis and psoriatic arthritis patients initiating Secukinumab. What do they find? Well, they find in this large real-world study of patients with both axial spondyloarthritis and psoriatic arthritis initiating Secukinumab that for the first time they were able to report 48-month retention rates and the rates of remission and LDA, and they found the retention rates after. They also report a retention rate after 4 years and in approximately 50% in both axial spondyloarthritis and psoriatic arthritis. Biologic and targeted synthetic DMARD naive patients demonstrated higher retention, remission, and low disease activity rates than patients with prior biologic and targeted synthetic DMARD exposure, particularly in axial spondyloarthritis. And it's important to remind that this is indeed a very long follow-up period, where these numbers are being presented for. So in order to conclude, this is a large European real-world study. It's important to always point that out because, as also mentioned at the beginning, we do not have data on this real-world situation, demonstrating that 4-year Secukinumab retention rates are approximately 50% in both axial spondyloarthritis and psoriatic arthritis, and those patients with biologic targeted synthetic DMARD no pretreatment had high retention rates, remission, and low disease activity as compared to patients who have had this exposure before. So overall, I think very interesting information. And of course, it's important for us to understand that information even better because we're using these drugs in our daily practice. I don't know how you see that.
Yes, thank you very much, Xenofon, for this nice overview of this study. I think we can comment on several things of it. I think drug survival, which is the outcome that was mainly used, is indeed a very important outcome in our daily clinical practice. As you were saying, drugs that we are using, it is believed to reflect effectiveness because it's simple. If a drug is not working, usually it is discontinued. On the other hand, there are other factors that influence drug survival, and we know whether there are more options or not available. that the patient will discontinue more or less if there are less options available. So depending on the calendar year when drugs were started, and also trends, habits, protocols within each institution. So it's very difficult to disentangle the effectiveness information solely on effectiveness from discontinuation. And also, I think there's a clear message here that in patients that have failed more 2 or more DMARDs, biological targeted synthetic DMARDs, they have a lower survival of Secukinumab. This is indeed what I think we all see in daily clinical practice. There's also here some parallel, although not fully being the aim of the paper, but to the definition of difficult to manage that has been recently published by the ASAS group, and in which indeed patients that have at least a failure of 2 biologic or targeted synthetic DMARDs with different mechanisms of action, so it's a little bit different than only this, are patients entitled to fulfill the definition of difficult to manage. So those are patients that we recognize from our daily clinical practice that are more difficult to manage, more difficult to achieve the most stringent outcomes that we want our patients to achieve. Maybe you want to comment on this?
No, I fully agree. Regarding that concept, we need to take this data also into account, not because we have one maybe failure of a biologic or targeted synthetic DMARD before, but rather because we now switch the mode of action and still the retention rate looks to be lesser beneficial as compared to the primarily treated patients with a biologic. And this to me tells also additionally 2 things. First of all, we do not really know what we're doing to these patients who do take a biologic and fail it if we're changing something within the patient, or if that change of the biologic had to do, or let's say, or the non-response feeling in daily practice had to do with other reasons for having non-response, what may not have been appreciated in the beginning, such as secondary reasons for pain and so on, and hence also the second drug or the second attempt for treatment did not really work well. So this shows why it is important to really be able to define difficult to treat situations. And this shows also that in daily practice, we deal with more than just disease activity, and we need to take that into account before we appreciate or before we think of switching to another mode of action or switching the drug overall.
Yes, totally agree with your thoughts. And I could also add that the challenge of doing this type of analysis in daily clinical practice, although they are very necessary, of course, and here we have a clear strength of having a collaboration from 13 registries with a large number of patients. The challenge remains in taking conclusions when we compare data. So in this case, data are more descriptive, and the comparisons are, for example, in patients that have failed 1 biologic or more biologics before. So those are more straightforward. But if we want to compare, for example, different drugs on which patients are selected to be treated on, there's not really a random selection of patients. And of course, there's some confounding by indication. So that is an additional challenge in which that we have to consider. So who are these patients that a lot of patients have failed 2 previous biologic or targeted synthetic DMARD. So it's not a population that is representative of our patients who are naive for biologic or advanced treatment in general. So those are aspects to take into account, I think.
Absolutely.
Any other aspects on this paper you would like to highlight, Xenofon?
I think at the moment we have covered everything. It's still important to remember that we have, as you mentioned, 13 registries altogether, which is still, on the other hand, something as an effort, which is very nice and positive, that really European collaborators are working all together to really improve patients, or let's say our knowledge of patients' treatment.
Definitely, I agree. And I think it's good to finish on that positive note on this paper because it's important to emphasize those efforts. So I think we can move to the second paper. And now the paper is entitled Effects of Secukinumab on Skeletal, Microarchitecture and Vertebral Fractures in Patients with axSpA using CT by Heiting and coworkers. So axSpA is linked to poor skeletal health, with patients paradoxically forming and reabsorbing bone leading to frequent complications such as osteoporosis and fractures. While on the one hand, IL-17 blockade is effective in improving symptoms in axSpA, its effect on skeletal health remains uncertain. And Heiting and colleagues investigated whether the initiation of IL-17 blockade with the Secukinumab improves bone turnover, bone mineral density, and microarchitecture in patients with axSpA. So in actual patients with axSpA who had moderate disease activity and who began with the Secukinumab, there were improvements in clinical symptoms and function, so as expected, but actually there were no change or small declines in bone mineral density and microarchitecture, and no change in bone turnover markers. Contrary to the hypothesis that the authors had, that skeletal health as measured by densitometry, and in this case with the CT that they used, peripheral quantitative computed tomography, and bone biomarkers that they would improve. So this is what the hypothesis. In the end, they found little evidence of improvement over 2 years of Secukinumab therapy. So despite symptomatic benefits of treatment with Secukinumab, with improvements in pain and in function, there were few biochemical, densitometric, or microarchitectural changes in skeletal health over 2 years of patients treated with the Secukinumab. So in conclusion, although participants experienced significant improvements in axSpA disease activity and function over 12 months of treatment with Secukinumab, there was no improvement in bone density or microarchitecture, and small but significant deteriorations were observed over time. We need larger and longer term controlled studies using sensitive metrics, such as the peripheral quantitative computed tomography, to follow bone quality, so that we can learn how to improve our understanding of how bone health in axSpA and relation to disease activity and to treatment. So I think this is an interesting study, and I think it caught our eye because we select these studies for this podcast by a team of several members from the steering committee, and I think we all got the eye of the study in terms of the purpose and what it wants to analyze. But we have to admit that there are also limitations in the study. It's a very small number of patients. 22 patients were included, which limits the power to take any conclusions. So it's not very strange that there are no real improvements in bone health over a relatively short period, over a very relatively small number of patients, and actually without a control group, so that we cannot really take conclusions on the attribution of what is happening or not happening. What do you think about this study, Xenofon?
Well, you mentioned all the issues that I would have with these results indeed. 12 months, I believe, is very, very short to really see any kind of effect. And we also have to take into account that these patients have already been having disease activity, or they've been dealing with a disease for longer periods. So this means that overall, there might have been processes that just need longer time to see where we see an effect on. And the other thing is that, so I do believe there is an effect, but most probably the authors were not able to catch it here and to capture it here. And the other thing is, of course, not only whether or not what was captured here is relevant for the bone mineral density, but of course also what happened to the radiographic progression, which we know is in fact what we do want to stop. This means we want to stop new bone formation, but we also want to increase new bone formation within the bone, which is a little bit of a contradiction. So altogether, my takeaway here would be that it is interesting and also food for thought, but I would not see this data as the final result.
Yes, I totally agree with you. In that sense, I do not have much to say on that. Maybe I could add some thoughts or some literature that we know on. Actually, as you mentioned, our one of our big outcomes or big aims is to inhibit structural damage progression and the formation of syndesmophytes. Osteoporosis has is a known predictor of, or has been known for being a predictor of syndesmophyte formation. But on the other hand, several studies have not confirmed this, especially when we take into account the variability within the patient and the correlations across the vertebra of the patient. So there is a clear association between inflammation and osteoporosis. So inflammation leads to osteoporosis. There's also a clear association between inflammation and damage, bone formation, but that there does not seem to be a clear association between osteoporosis and bone formation. And there were several studies conducted, even managing the limitations or addressing the limitations of the studies. There does not seem to be a relation.
Thank you for commenting on that. I believe this is indeed what the audience has to take away from this small study. Still, again, interesting to have reported it, especially because this was also a high resolution CT examination, which does add some value here. All right, I'd like to then close the podcast for now, and thank you, Sofia, for bringing up these topics and discussing this with me. Thanks to all of you for joining us in this axial spondyloarthritis podcast brought to you by the Immune-Mediated Inflammatory Disease Forum. We do hope you enjoyed and found it useful. If you did, please do not forget to subscribe to our channels on YouTube, SoundCloud, Spotify, or wherever you get your podcasts from, so that you do not miss any future episodes. If you do want to read more about what we've discussed today, head over to the site www.imitforum.com, where you will find a summary slides of today's publications. See you next time.